Hello, I'm Rohit Gosain, a community medical oncologist, alongside my brother, Rahul Gosain, another community medical oncologist, and we are the Oncology Brothers. Today, we are talking about the clinical insights on how this field is moving. In 2025, we saw multiple drug approvals. However, one of the more impactful one was perioperative Dervalumab with chemotherapy, based on Matterhorn study. To talk about that and data in hand and more, we have an great panel, starting out with Dr. Stephen Maron from MSK, Dr. Reetu Mukherji from MedStar Georgetown, Dr. Alistar from Atlantic Health, and Dr. Raji Shameem from Orlando Health. Welcome, everyone.
Thank you for being here today. Before we get into the Matterhorn study, just as background, when it comes to early disease for G-junction or gastric adenocarcinoma, historically, we've been worried about local control. That's where cross-trial came in with concurrent chemoradiation. And we quickly realized that it's actually the micromets that we have to worry about. That's where ESOPEC reaffirmed that this should be the standard of care. Peri-op FLOT, surgery, and then post-op FLOT. Then the question was, how can we do better? That is what got Dervalumab FLOT, surgery, Dervalumab FLOT, and then ongoing Dervalumab with Matterhorn approved. Let's start there. Steve, can you start us off with the Matterhorn study design, which led to the approval of Dervalumab in this space?
Absolutely. So with Matterhorn, patients received FLOT4, our standard paradigm now, for many years with 4 cycles of FLOT prior to surgery, followed by surgery, and then 4 cycles afterwards. In this case, patients also received either Durvalumab or placebo, and this is a randomized trial. What's also unique here is that not only did they have the concurrent Durvalumab for the 2 months pre-op and the 2 months of adjuvant concurrently with chemotherapy, but then an additional 10 months of adjuvant Dervalumab alone as well, every 4 weeks.
Well, thanks so much for laying that foundation. Ritu, what we saw initially presentation was at ASCO 2025, and then we saw updated data at ESMO 2025. Could you go over the findings that we learned from ASCO as well as ESMO with regards to Matterhorn?
Sure. So the initial data that we got from this randomized phase 3 study was really the pathologic complete response data at first. And what we saw is that compared to perioperative or neoadjuvant FLOT alone, FLOT plus Durvalumab improved the path complete response rate from about 7% to 19%. So we saw a signal that there was more effect at the local level based on path complete response. And then the more recent data that was presented was actually one of the primary endpoints, event-free survival. And they reported data at the 18-month and 24-month mark for event-free survival. And at 2 years, we saw the EFS was about 59% compared to 67%, a delta of about 8%, which really affirmed that perioperative FLOT plus Durvalumab was a superior arm in this randomized study.
Thank you for touching on that. Coming where I started with that local control, I think that PCR is impressive. However, to see that event-free survival, to see that overall survival address the micromets, I think is a lot more meaningful in this particular settings. Angela, one thing that we always worry about is anytime we're adding a new option in the peri-op settings, is this going to compromise my surgical outcomes? Thankfully, that was not the case. Can you build up on this a little? What did we see with the control and the Durva FLOT arm in terms of the surgical outcomes?
Yeah, I think it's an easy decision to make by medical oncologists because the toxicity of the combination doesn't really come as much from the immunotherapy, but it comes from the chemotherapy. We are all now proficient in managing FLOT toxicity. So adding immunotherapy doesn't really fluster the medical oncologist very much. Of course, autoimmune toxicity can happen, and it will happen in some of the patients. But anytime I have to present FLOT toxicity and immunotherapy toxicity, it's really very clear that the toxicity will be mostly driven by the FLOT, by the chemotherapy combination. And that is what gets modified most of the time. From the clinical trial results, the autoimmune toxicity did not lead to any kind of inability to go to surgery, did not exclude patients from surgery. It was not added toxicity that would make the surgeon concerned or the medical oncologist or the patient. So I think in the neoadjuvant and adjuvant setting, immunotherapy did not translate into higher toxicity or impacted survival negatively. So I think it's a very easy to adopt regimen from that standpoint.
Yeah. And to put it in clinical context, in both arms, roughly about 10 to 15% did not make it to the surgery.
Right.
So when we're comparing it to FLOT versus Durvalumab FLOT, it was encouraging to see that we're indeed, thankfully, not compromising those surgical interventions.
Yeah.
Raji, in our discussion with Dr. Yelena Janjigian, who was one of the top leaders who participated in the clinical trial, she mentioned was that she has not utilized chemoradiation therapy approach in past 7 to 8 years, and rightly so, because now we have learned better to manage the FLOT regimen with dose modification. So we'll have to broadly agree where we stand that with this impressive data, that is rather the new standard of care, and we have adapted this in our practice. The question is, who is not that patient that you will utilize this therapy and rather consider chemoradiation?
I think that's a very relevant question. We want our patients to have the best outcomes. We also want to acknowledge toxicity that occur. Because as you mentioned, the addition of Dervalumab to chemotherapy, not much difference. And yes, there are those rare immunotherapy adverse reactions, but overall, as we saw in the trial, majority of patients were able to undergo surgery, and a large number of patients were able to complete adjuvant therapy, including those 10 additional months of Dervalumab. I think there are certain patients who are not candidates who would not be able to receive any immunotherapy agent, right? Active autoimmune disease, Crohn's, ulcerative colitis, those are the ones who will never get it. But I always feel like 3 drugs matter. I know I've been using FLOT for a while, right? I believe docetaxel, 5-FU, and oxaliplatin, it makes a difference, right? And in my practice, I try to offer all my patients those drugs, acknowledging dose reductions might be required, right? And when I have the discussion regarding the outcomes, I would say we can try it, right? If there is, I'm not worried that they might have to stop the thing, but I offer it, right? But absolute contraindications of immunotherapy, that's one reason. But majority of patients, I feel they're candidates acknowledging dose reductions and stopping chemotherapy might happen.
Absolutely.